All right. Well, it is 12:03, and I think it's the appointed hour to begin. Welcome, everybody. I am excited to see you all here for our December edition of the CodeX Fire Accelerator Community of Practice meeting. So thank you for registering. Thank you for your interest. Thank you for attending. Here's what we've got in store for us for the next hour. You'll hear from me for a few minutes, giving an overview of CodeX, and of course, this welcome. Then we get into the meat of our presentation. The iCAREdata team will be presenting on the successful closeout of their use case and their work. We'll hear about where that's going and what sort of things they've learned. Then we'll hear from an active use case, the Quality Measures for Cancer team. They'll give us an update of what they've been up to. And then we will close out with some news and upcoming events. And hopefully we will stay really tight to our agenda. So let's get this party started. Now, I know that many of you have longstanding engagement with fire accelerators and with CodeX in particular, but there may be some folks here who are relatively new, who have joined because they have an affiliation with this with the work that's being presented today, or they may be friends or colleagues with somebody who's presenting. And as such, I thought it would be prudent for us to just have a quick overview of what is CodeX, what brings us all together today, and why might you be involved? Why might you be interested in being more involved in the future? So first off, CodeX is a not-for-profit, diverse stakeholder member group. We operate under the aegis of HL7, the Standards Development Organization, and we gather the community together to solve some of the trickiest problems in healthcare using HL7's health data standards, in particular HL7 FHIR. Our purpose is to break down data silos to deliver better healthcare, better research, better patient experience, again, using health data standards. And we do that by convening a community of stakeholders from various parts of the industry who can together solve from end to end real problems using these standards and can publish these solutions in an open source way. And we believe that this sort of consensus approach is really important to the world and is really effective and results in solutions that are not merely academic or esoteric, but are in fact practical and scalable and usable. The CodeX community is one of the fire accelerators that HL7 supports. And the CodeX Fire Accelerator is made up of 3 domains. Our original domain, CodeX's birthplace, it's in the oncology space. And we're grateful to the work of MITRE and ASCO and others who initiated that work. Since then, since CodeX was founded, 2 other domains have been added to our purview, and we now serve the cardiovascular domain as well as the genomics domain, and we have cool logos and brand names to associate with each of those domains. But fundamentally, we together are one fire accelerator called CodeX. Within each of these domains, there are a number of use cases. A use case is a particular problem space which has been identified by consensus within our community as a problem that we have the resources to address, that we have the right team together to engage, where we think that we can make a meaningful impact in the world. And so, as you can imagine, our initial domain, the oncology domain, has the most use cases, as you can see here on screen. And we're going to hear from 2 of those teams today, and we're excited about that. There are also on the right a number of use cases that are in our newer domains. And this list is growing, and we're excited to see these areas thriving and seeing lots of engagement there. Of particular note, each of these use cases are at different stages in their life cycle. Some of them, like the iCAREdata one, which we'll be hearing about today, is at its conclusion. The work has been done. We're here to hear about the lessons learned and to celebrate that success. Others, like the Quality Measures for Cancer use case, are in the middle of execution. They're getting things done, and there's a real engagement with their members to do that work. Others of these are in the very early stages. In the bottom left, you'll see Data Direct, for instance, and you'll hear more about that later today. But this one is in a very early ideation stage, and is just starting to get off the ground. And so each of these use cases goes through its own life cycle. Over on the right, we have recently moved REMS from planning into execution. We're seeing a lot of engagement there, a lot of new membership in CodeX as a result of that work. And so it's just neat to see each of these use cases coming and going and making an impact where it is. Moving forward, here we go. In addition to the work and the use cases of CodeX is, of course, the membership of CodeX. And as I mentioned before, CodeX is a community organization made up of all sorts of different stakeholders. And so this eye chart, I apologize for the quantity of data on this sheet, is intended to show some of the breadth and depth of our membership. We're very pleased to have professional organizations and associations, having vendors, having regulators, having tech startups, having all sorts of different folks from different parts of the space working together to solve problems. And we believe very strongly that the power of CodeX is in its membership. And so we're very proud of the community that we've convened together. Actually, before I move on, it's also important to note, as I mentioned before, that as each of these use cases goes through its life cycle, there's a more active phase in the planning and execution phase of each of these use cases. And as a result, organizations will come in to be members for a period of time, will help serve that use case that they're interested in. And then naturally, as some of these use cases conclude, some of the memberships may become, less necessary or less practical. And so some organizations come and join for new use cases. Others may choose not to renew when they're finished working in a use case. And that's natural and it's healthy and it's part of the broader life cycle of our organization. That said, soliciting new membership is an important part of our job. And so we want to make sure that you understand the opportunities that are available to you. This membership categories table comes from our public website, so you can feel free to look it up there as well. But it shows that there are different tiers of memberships with different privileges and different responsibilities. And that comes with resource allocation, including finances. CodeX is about, of course, convening a community, but it has financial needs, of course, that need to be met, and membership fees are how we do that. And so it's important to keep that in mind. If you have interest in CodeX, but you're concerned about the membership fees, please don't let that be a barrier. Please do reach out to us, and there are ways that we can find to help you meet your objectives and to ensure that we have the broadest possible engagement here at CodeX. So finally, before I pass it off to the important part of our meeting today, I would encourage you to consider, if your organization hasn't joined CodeX, that you would consider membership in CodeX for three major reasons. One, to support the public good, to help make healthcare better in the world, more efficient and more effective. To build your organization's reputation by participating in multi-stakeholder organizations. You're leading the way in healthcare, and you're also showing your commitment to making things better for everyone, and your willingness to collaborate with peers. And finally, there are tangible benefits in participating in CodeX: access to a network, increasing your reputation, being able to demonstrate that your solution or product has consensus and has a community behind it can be of real benefit to you and your organization. Of course, that benefit is realized differently, whether you're a vendor or a professional association, or whether you're a government regulator. Your tangible benefits change by type, but we believe that the benefits in CodeX are real and do accrue to our members. So thank you for listening. And if you have any questions about membership, please do reach out to me or any member of the program management office here at CodeX. And with that, I will pass it off to our iCAREdata team. Hello, Maeve. And I'll drive the slides if you tell me when to proceed. And I'll turn off my camera now and leave it to you and your faces to move us forward.
Thank you. Good afternoon. My name is Maeve Kokolis, and I've served as the iCAREdata Use Case Coordinator for the past 3 years. We're really thankful for the CodeX community for giving us the opportunity to share with you the results of our use case. Next slide, please. So today we're going to provide an introduction to iCAREdata, talk through the technical implementation, and also present some of the results and our lessons learned. Presenting today will be Dr. Stephen Panadosi. Dr. Panadosi is a professor in the Department of Surgery at Brigham and Women's Hospital and a professor and resident at Harvard Medical School. He serves as the Associate Group Chair for the Strategic Initiatives and Innovation for the Alliance for Clinical Trials in Oncology, a national clinical trials network sponsored by the NCI. He is a lead member of the Statistics and Data Management Center for the Alliance, Director and PI of the Alliance Data Innovation Lab, and one of the architects of iCAREdata since its inception. Also talking today will be my colleague, Michelle Cassani. Michelle is a Principal Health Informaticist at the MITRE Corporation. Currently, she serves as the Site Integration Lead for iCAREdata and is the co-lead for the Vulcan Adverse Events Project. In these roles, she is driving FHIR-based health data standards to improve interoperability for clinical care and research. And we can have the next slide, and I will turn it over to Dr. Panadosi.
Hello, everybody. Thank you, Maeve. It's a pleasure to be here today and give you a report on the progress we've made with this iCAREdata use case. Next slide, please. So the philosophy behind iCAREdata from its very inception, going back now 5 or 6 years, is to be able to use a larger fraction of the data that arises during transactional healthcare, particularly in the clinical trials laboratory, but always with an eye on broader use of the data beyond classical clinical trials. At the top of this diagram, you can see the way that data are used traditionally in clinical trials, where in the cancer domain, we recruit fewer than 6% of cancer patients to participate in those trials. Nevertheless, from that small fraction of patients, we generate very high quality data designed for specific therapeutic question. And those data are in a clinical trial database, and they contribute to selection of new therapies, comparisons, and so on, that is, to a learning health system. The vision of iCAREdata, however, is that we would leverage data from 100% of cancer patients, and that would be accomplished by structuring the data in the electronic record before it needs human curation. In fact, eventually to completely eliminate the step of human curation. And that structured data model would be based on M-code, which I'm sure you're all familiar with, and it would be structured for routine cancer care and transmitted using FHIR resources to a database so that 100% of cancer patients would eventually contribute to the learning health system. Next slide. So with that philosophy in mind, the iCAREdata team has entered into collaborations with MITRE, whom you'll hear from in a moment, Epic Medical Record. The US FDA has provided a substantial amount of funding to us, as well as the National Cancer Institute. And our research laboratory has been the Alliance Clinical Trials Group, funded by NCI as part of their NCTN resource. So I won't read the vision to you. I think it's consistent with the philosophy, but part of what we do in implementing our technical methods is to make assessments of the quality of those technical assessments, as well as the impact on the workflow for the physicians and support staff engaged in clinical trials. And again, an ultimate goal here is to eliminate the expensive and time-consuming human curation of data that is currently the standard model for cancer clinical trials. Next slide. The strategies that we've used are listed here. First, it has to be low burden, consistent with our attention to the workflow issues. We need a standardized data model, hence M-code. We have focused on key data elements that are essential to research and patient outcome. You'll hear a little bit more about those in a moment. And the automated extraction that we've implemented enables us to put these methods in a variety of institutions with different levels of resource. And the data that we're interested in is central to research outcomes. Two data elements in particular that are essential for that, but have been represented typically in the electronic medical record by free text or other forms of non-computable data. One is the status of the disease, and the second is an implicit recording of treatment failure that is through indication that a treatment plan will be changing. Next slide. So I think this is the point where I need to turn this over to Michelle from MITRE. Do I have the right slide, Michelle, or one more?
You can talk to this one, Stephen, and then I'll go into the technical details.
Very good, thank you. So indicated that there were two elements of data that are necessary for many of our research questions that are typically poorly represented in the EMR. They can be curated. Sophisticated clinician or research support staff can interpret these in the note, but this represents the iCAREdata structured form for those elements. The first is cancer disease status, collected via a smart form in the problem list in the EPIC record. And you can see in the question and the choices in the drop-down menus, this controls the vocabulary that's used to establish the disease status. It's the blue boxes represent single choice drop-downs, the red dotted box potentially more than one choice. The second question has to do with change in the treatment plan. This is also a controlled vocabulary question implemented as a smart phrase in the encounter note, and here a single choice only. So by standardizing these responses and putting them in M-code format, if you will, or following the spirit of M-code, it makes these much more easily distracted and not as subject to interpretation. Next slide, please. So how we did this is has some important technical nuances that I'll turn over to Michelle now to describe.
Thanks, Stephen. Next slide, please. So when iCAREdata launched in, excuse me, in 2018, the natively exposed interfaces for FHIR and M-code and EHRs were not readily available. Therefore, the iCAREdata team developed this technical approach that's pictured here so that we could capture, extract, and transmit data to validate this automated standardized collection of the oncology outcome data directly from the EHR. The iCAREdata implementation is EHR agnostic. However, for this project, we partnered with EPIC so we could support the site-specific requirements of how that data was captured in the EHR. For the data capture, EPIC supported a smart form on the problem list to capture cancer disease status, and a smart phrase was used in the clinical note for the cancer treatment plan change. This allowed those iCAREdata questions to be captured at the point of care directly within the EPIC user interface. For data extraction, the required data elements were queried and saved in comma-separated value, or CSV files, And then MITRE developed an open source iCAREdata extraction client to format that data from the CSV files into an M-code-based FHIR profile, and then transmitted those FHIR resources to the iCAREdata infrastructure using FHIR messaging. The iCAREdata infrastructure is a secure cloud-based architecture based on Amazon Web Services GovCloud platform. All of the data is secured in transit, and it was encrypted at rest, and access was restricted to authorized individuals. So as EHR vendors begin to implement these standard-based interfaces, interim solutions such as this extraction framework will no longer be needed. Next slide, please. So as I stated, we partnered with Epic, and we also partnered with several clinical sites to collect this data at the point of care and extract it from the EHR, transmit it through the automated FHIR interface, and then it was used for analysis. And so this picture here is just showing the high-level steps that were required by the sites to participate in this iCAREdata project. So to implement the data collection tools, the Epic analysts at each of the sites configured their Epic instance with the iCAREdata smart form and smart phrase. And they were also responsible for generating those queries to extract that required data from Epic and save it in the CSV files. Clinicians and research team staff received training on how to use these Epic tools so that they can complete the iCAREdata questions each time they had a patient visiting. And then to implement the data extraction framework and transmit the data, the information technology staff downloaded and installed the iCAREdata extraction client on a host machine within their network. They configured it to point to the CSV file location of those queries that were extracting the data from the EHR. And then they scheduled automated jobs so that the queries and extraction client would run and transmit data on a monthly cadence. This implementation followed the iCAREdata strategies. It focused on patient outcome data. It was low burden, standardized, and automated. Next slide, please. So we were successful in confirming the value and technical feasibility of data standards for structured data capture, extraction, and transmission of point-of-care data to inform oncology research. However, we did identify some challenges, many of which arose from adapting existing technical infrastructure to demonstrate the components of this future state. So related to the implementation of the IT, there was requirements that were specific to several of the clinical sites, such as sharing EHR instances, and this introduced some delays in implementation. There was also some site security requirements that would also expose some of the delays where they had to do risk assessments before they can install some of this software. For the clinical implementation tools, answering the iCAREdata questions did require changes to the existing clinical workflows, and adopting these new workflows did present some challenges. For example, the interpretation of the responses for cancer treatment plan change varied, and several clinicians indicated that answering the cancer disease status through the problem list was burdensome. And there was also an increased workload answering these questions if they were done post-visit, if it was not done during the actual visit. Related to the data, we did do testing prior to moving the implementation to the production site, but it didn't capture all of the data quality issues. Testing with the synthetic data allowed us to identify any issues with the CSV file formats, but not all of those quality issues were uncovered. Like we did realize after we started passing real data that there was instances when the treatment response change answer was no, there was no date. But there was also some quality issues that really couldn't have been discovered until we had that real data flowing. And one of these examples was the cancer disease status. We weren't able to identify discrepancies in that data until we had multiple data sets that we could compare. And this turned out that some of the results were missing because it was how the queries were generated. They were only pulling data from the current status for cancer disease status and missed taking the data from the historical tables. So again, as these standard workflows and data standards such as FHIR and M-code are adopted more broadly, many of these changes can be mitigated. And I'll turn it back over to Stephen, who can cover results and lessons learned.
Thank you, Michelle. Next slide, please. So in addition to the technical challenges and lessons that Michelle has indicated, we have learned quite a lot about the use of these data and their consistency and potential inconsistencies with data collected through the usual curated pathway. We had a number of partners and important milestones. Here are some of them: making the smart tools available and implementing the extraction client. The data were collected, and then we performed a concordance analysis in March of 23, comparing data collected through a curated pathway with data collected directly from the iCare pathway. We took feedback from our clinical partners and sites based on surveys that we did, and then took the lessons that we learned and implemented new smart forms that we hope corrected some of the defects that we observed. And in a smaller series of data, and surveyed the results and examined them as of August of this year. Next slide, please. Here's the data from March of 23. It's important to understand that we had more encounters later in the year, but based most of our analyses on the analysis set from March. You can see we got answers to both question 1 and question 2 that I sketched for you earlier in a substantial number, but not 100% of the patients who were encountered in clinic. Question 1 only was answered rarely. Question 2 only on treatment plan change was as a solo answer more frequently. Part of the reason for this, as I indicated, is that these questions were located in different parts of the electronic record and subject to simple or routine encounter depending on the natural workflow for the individual as well as the clinic. Next. The concordance rates for the 2 questions were high for treatment plan change, lower for cancer disease status. However, when disease evaluation was reported, both via the electronic record and electronic data capture, there was a much higher rate of concordance in the CDS. We noted that interpretations varied depending on the response option and its immediate or local interpretation, and also by the nature of who was providing care and providing the answer to the question. I mentioned that the location of disease status in the problem list was burdensome or a problem many of our providers did not like leaving the note and going into the problem list. And also we had somewhat longer than ideal timelines for contracting for this work with the sites as well as the technical implementation. So we know that based on our data and experiences as well as user feedback, there's a high degree of technical feasibility for using M-code as a data model and implementing these kinds of structured questions in the EMR, potentially leading us down the pathway of eliminating human curation. However, we still had further to go in terms of making sure that all users understand exactly what's meant by the answers in the context of the patient encounter, and also minimizing site burden through appropriate choice of workflow and location of the structured questions. Next slide. This led us to redesign our iCAREdata questions into an integrated smart form indicated here. You can see both disease status and the treatment plan are in the same smart form based on our feedback. We also added some new terms to try to enhance understanding and remove any ambiguities in how these questions are interpreted. So using what we learned about the location of the note based on the feedback and shortening of the responses, this smart form was implemented at a handful of sites and provided us with new feedback from the users. Next. So this represents an evolution, if you will, in the initial iCAREdata approach. These are samples of some of the kinds of feedback that we got, good and bad. And I think it's important to understand this context that most of our providers in the clinic are quite used to therapeutic research and using new treatments, drugs, and so on. Less use, perhaps, to implementing research on data capture methods within the clinic. Many of our clinical staff also feel that they have alert fatigue and other issues in the use of the electronic record, and they're very sensitive to changes that might require alterations in their workflow. So I won't read these comments to you, but you're welcome to look at the slides that are provided from this meeting and try to digest exactly what these mean. We took these and other comments to heart in our revision, as we will be doing for our future work in iCAREdata. Next slide, please. The new smart form, as I indicated, was a response to some of these comments. We know that workflow is still an issue, although we do have users who are quite used to using the smart form approach. For example, our clinical partners at ThedaCare use this smart form for all their patients. So they're, in that sense, almost at the goal of collecting this structured data routinely. We have other institutions, though, that are less far along in their acceptance and willingness to alter the workflow in the clinic. There is a sense of perceived burden, as I indicated, because of the fatigue and the tight timelines, keeping clinicians and providers in their routine and apparently efficient workflow. However, we believe that the smart form tools, once habits change, will actually shorten time, increase the reliability and computability of these key data elements. Next. So here's some of the lessons that we've learned in the initial iCAREdata and the reasons that we're closing out this use case and moving on in the evolution of this work. We know to engage project champions overall, as well as at the institutions. Our sites are all different. Every installation of the EMR is different, even if it's a common vendor. And so we need certain specificity at each of the sites. We have to communicate regularly and define the roles and responsibilities at the sites. For example, for the use of IT resources, we've learned to implement steps in parallel, the use of synthetic data sets to identify quality issues, and to provide flexible options for integrating these tools into the clinical workflow. And those lessons will be carried forward in the next phase of what we are planning. Next slide. For those of you who'd like to dig a little deeper into what we've learned, there are three publications. The first is the more technical paper. This one will be in JAMIA Open. That manuscript is in press, has been accepted. The second paper has already appeared in Cancer, and it details some of the successes and challenges that we encountered that I described here in this talk. The third paper is from colleagues at Mayo Clinic who've implemented similar methods, and Dr. Tavar work is now part of our iCAREdata team. Next. So going forward, using what we've learned and building on the lessons in those publications, we are going to continue to work leveraging the use of real-world data in a new project. This use case is called Data Direct, and it will carry forward the spirit as well as the practicality of eliminating human curation in the acquisition of these data. We would, for example, like to conduct the first clinical trial without the need for any traditional CRFs and demonstrate that this is feasible and it can address a real clinical question in a real-world clinical trial. And certainly if you're interested in joining this effort, there's contact information for us at the Alliance Data Innovation Lab. Next. So Q&A now. Let me pause and just see if my colleagues, Maeve or Michelle, have any additions to what I've said in this talk, and then we'll take questions.
Thanks, Stephen. Nothing to add, but I do want to say Maeve just put in the chat the link to the technical article that was actually just available online as of a day or two ago. The actual journal's still in process of publishing all of its articles, but ours is showing up. So the link is in the chat. Thank you.
Great. Thank you, Michelle. Thanks, Maeve.
Any questions for the team from our broader audience? Hearing none, I suppose thank you is in order. Thank you to the team for your great work, and thank you for your excellent presentation. Do you have any closing comments before we pass things on to our quality measures team?
Just quickly, thanks for the opportunity and the attention. I'm very appreciative for the comments that have come forward, and I'd like to say publicly thank you to all of those who participated, especially our colleagues from MITRE who have been absolutely essential to this, and our iCAREdata staff and clinical partners. Thank you all.
Thank you, Stephen, and thank you, team. And with a virtual round of applause, we will move on to our second presentation, which is from the Quality Measures for Cancer team.
Welcome,
Hello,
everybody.
Gail, over
Yep.
to you.
Thanks, PBO. And thank you to everybody for joining us today for an update on the CodeX quality measures use case. Next slide. So my name is Gail Shank, and I work in health standards and interoperability at MITRE. And I've been the co-use case lead with Doug Williams for the last few months. I transitioned this work from Anthony DiDonato, if you remember him, who kicked off these efforts about 2 years ago. So today we're going to hear from some of the leaders on the use case, starting with Doug, who is a lead developer at the MIT Martin Trust Center and founder and CTO of Centennial Park. Stephanie Jones, who is Director of Performance Management at ASCO, and Aaron Crum, who is a Senior Director of Quality, Strategy, and Innovation at McKesson and the U.S. Oncology Network. Next slide. So Doug's going to start us off by talking a little bit about quality measures and their importance, and then share the motivation for the use case, the participants, and the impact of this work, as well as the approach that we've taken. And then Stephanie and Aaron are going to talk to the major challenge that we discovered and provide their thoughts on next steps that the use case is considering as the second phase of work has just been completed. So next slide. Doug, turn it over to you.
Sounds good. Thank you, Gail. As most of the folks on the call are aware, quality measures are critical for overall quality improvements, for evaluation, really getting an objective measure of where we are in our treatment. They're also critical for pay for performance and value-based care. So today, most of the measures are calculated with manual means. And what we wanted to look here is, with the advent of the oncology data available through EMCODE, how far could we take the automation of generating electronic quality measures using this standardized data? So that was really the goal. We were able to pull together. Stephanie's representing ASCO, cross-disciplinary team. So we've got ASCO and ASTRO on the Cancer Society side, MITRE as a leader in EMCODE originally, and coordinating. Evernorth gave us a payer perspective, but also really their clinical side. So they were invaluable there. And then Telegen did the bulk of the actual authoring. So they were, we were taking measures from our members, and then they were leading a lot of the converting those to electronic measures. InfoWorks participated from a data management side. And then as we were beginning to move to the next phases, McKesson Ontario joined. They're already a leader in the CodeX community, and they were doing work in quality measures that we wanted to review and leverage. In terms of what we were able to achieve, we were able to convene this group, work through the phase 0, phase 1, and phase 2 that I'll outline in the next slides. We were able to author and test 2 proof of concept ASCO measures and antiemetic measures, taking the data, the EMCODE and FHIR data, and generate and create implementation guides for how to generate it. And through this work, we were able to, we had key data points that were critical for these measures that we're able to get incorporated in the critical EMCODE data elements incorporated into the USCDI versions, as well as USCDI quality initiatives through CMS and ONC. Next slide, please. So the challenges of the measures, as I'd mentioned, was today the data is largely in unstructured data. So EMCODE gives us the opportunity to bring it through structured elements. And we want to investigate creating systems that would generate these automatically. So the diagram on the right-hand side of this slide talks about on the diagram, the left portion is the inputs into the quality measures. We focused on the quality measure generation in the center. And then as a group, we talked about the different consumers of the quality measures at different points in the healthcare system. So providers need them, the government needs them, payers need them. So our work was all in the center in the generation point of view. Next slide, please. So in terms of where we got to, we were able to work through phase 0, phase 1, and phase 2. Phase 0 was really get the proof of concept, take some existing measures that we're generating using older standards and MIPS, convert them and document them using FHIR, and then ultimately execute those. Phase one, we wanted to expand the portfolio. So we had our 2 sample measures. We used that to define the methodology and the documentation. We wanted to prove that we could extend it. So we picked some VA measures and repeat the process. Do the manual crosswalks from the measures to the M-code and FHIR data elements. Telligent, again, many thanks to them. Becky Metzger and Gail Winters for the authoring work they did, and then to the team for answering their questions as we went through that. So we were able to go through phase one, demonstrate that our methodology was sound against additional measures. And then in phase two, next I'll go on, I'll review it in the next slide. We wanted to expand that. So next slide, please. So this is the phase two work where we took the ASCO measures, demonstrated that we could actually run them through the Telligent QI core data models and execution. We were able to do that successfully. Telligent was able to demonstrate that in their environment. We for the VA measures, the HER2 plus and BCA measures, we were able to use those and convert those for use in the CMS MADI tool, and transfer that ownership of that work to ASCO. And then as McKesson joined us, we were able to review the measures that they had been developing and working on, and take them through what the requirements would be to take them forward. So we took them to the requirements phase. So this gave us a broad range of measures to understand what the work was involved, whether we could execute them. We were able to do that, but this also uncovered a series of challenges and lessons learned, particularly in where we are with authoring tools, the manual work still involved, which Stephanie will discuss in the next slide. So next slide, and Stephanie, over to you and Aaron.
Thanks, Doug. I just want to reiterate our thanks to the Telligent team. Becky and Gail were really instrumental to bring us to where we ultimately landed, and we were sad to see that Telligent had to step away from the CodeX community given the other priorities, but they really were, the key drivers to the work that we were doing. So really the big takeaway here and our biggest challenge is in the current space, those measure developers like ASCO who are developing electronic clinical quality measures are required to use the Measure Authoring Development Integrated Environment, also called MADI. And unfortunately, this uses the QI core model, and the output is what we were using to then sort of integrate M-code. And this was all being done manually. So it was extremely burdensome. And so I use this graphic of the elephant in the room because we realize that really is the elephant in the room, is that this is going to stay manual unless we can get buy-in from CMS. So next slide, please. So as we were thinking through sort of where we are now and what the next steps are, we are going to reach out to CMS and Semantic Bits, who is the contractor who has developed and will be maintaining MADI, to discuss their roadmap. Because as I said, their current state is using QI core, and we want to find out if their roadmap includes the integration of future data models like M-codes, so we can move away from the manual and move to a more digital space. And then I'm going to hand things over to Aaron because, our thought is we're going to pause this work for now. But the U.S. Oncology Network and McKesson have some pretty exciting work they're going to be doing with CMMI, which we think could inform us coming back and reassembling the group. So over to you, Aaron.
Yeah, thanks, Stephanie. I think the bottom line is that there's a lot of opportunity here and a big appetite to head down this path. So to give an example, this past year, we've been working with CMMI regarding the Enhancing Oncology Model, the EOM program. CMMI has already dipped their toes in this arena, right? So they've allowed for what they refer to as a high-tech submission for the clinical data elements that are required for the EOM program. What that means is they're enabling a FHIR-based submission of these core standard required clinical data elements for the EOM program that are utilized for modeling performance tied to that program. So we at McKesson, utilizing the data from our EHR system, were able to utilize and test that high-tech FHIR submission, leveraging M-code for the EOM program. And it's been successful. We know of another EHR vendor as well that was dabbling in this space. Bottom line is that CMMI is very much interested in going down this path of enabling FHIR-based transmission of data tied to their quality programs. And the logical next phase of that is how to enable quality measurement for these regulatory programs as well. So I'm encouraged. I think that there's a lot of interest here to move in this direction. We've already started to explore the opportunity, as was just described, to transcribe or rewrite our quality measures leveraging M-code as well to kind of position ourselves to be able to support FHIR-based submission of quality measures and to really partner across the industry to make this a more viable solution that will ultimately reduce the burden on our practices to participate in these more meaningful quality measures. So with that, I'll pass it back to you, Stephanie, but I think the bottom line is that there's a lot of opportunity here and a lot of great work trending in the right direction.
Thanks, Aaron. Yeah, I agree. I mean, I think we all were very excited to be part of this use case. I know our medical informaticist, Yvette, kind of finally realized that she found her tribe. And this is a group that we loved working with. We definitely, like I said, we're not throwing in the towel. We're putting it on pause until we can, Erin and her team can complete their work. We think that we will have CMMI in our corner, so to speak, to rally to CMS and maybe work towards moving Maddie to a place where we can integrate additional data models like M-code and again, move away from the manual to a more interoperable space. So if you have interest in kind of joining this tribe and like I said, staying on the list as we kind of monitor the space and what moves forward when we come back to convene, please feel free to reach out to the PMO email address, which is provided here, as well as there's a link to all the work that we've done to date. So feel free to go and peruse that. And with that, I think that brings us to the end of our presentation. Next slide.
Great. Thank you very much to all of you. Thank you for the update and thank you for your work in this space so far. And we look forward to hearing what happens next. So we are, and I'm grateful to all of our presenters for staying so strictly on schedule. Thank you for that discipline. Just a last couple of matters as we wrap things up today. We've got a little bit of news and upcoming events. First off, we wanted to share that if you are a routine user of HL7's web properties, you already have dealt with this, but they about 3 weeks ago implemented multi-factor authentication to improve the security of their services, and we support that. Of course, that affects anybody who's using Confluence for HL7, which includes all of us here in CodeX. So if you haven't already, please read up on and enable your two-factor authentication so that you can gain access and maintain access to Confluence. If you have any question about CodeX-specific Confluence matters, I'm happy to help with that. But of course, if you have two-factor questions or account questions, I can't help you with that. The PMO can't help you with that, but the HL7 help desk is standing by for you. Second thing, upcoming events. We're getting awfully close to the January Connect-a-thon. The FHIR Connect-a-thon happens on the 14th through 16th of January. There's a bunch of CodeX participation. We're hoping and expecting the Genomics team to have 2 tracks in the Connect-a-thon. That's still being finalized. If you have any questions or would like to participate, please reach out to me and I'll connect you to the right folks on the Genomics team. Also, the REMS team will have a track at the Connect-a-thon. And I believe registration, or at least early bird registration for the Connect-a-thon, that's coming up. The deadline is coming up next week. So don't tarry on that. If you'd like to participate in either of these or any of these tracks from these 2 domains, please do let me know and I'll make sure I connect you to the right folks. I'm sure they'd love to have you engage with them. Also, if there's any other CodeX folks here on the call who have other Connect-a-thon engagements that we don't know about, please let me know. That'd be great. As a follow-up to the opening bits where I was presenting about the value of CodeX and how membership works here, if you have any questions or would like to maintain this conversation, if you'd like to learn more, please email us pmo@hl7codex.org and we'll be sure to answer your questions or meet with you and understand what you're after. And with that, it is 12:59 here in the Eastern Time Zone. And so I want to thank you all for your time and attention. Thank you to our use case leadership teams who have done all this great work presenting today. So thank you very much for those updates. And I wish you all a great weekend when you get there. And with that, I'm going to stop the recording and wish you all a great day.
Thanks, Bivio. Bye, everyone.
Thank you.